Hello, everyone. Welcome back again. This will be our last um, part of our discussion for the routine urinalysis. This is the third part of your UA, which is the microscopic examination of your urine. All right, so are you ready? Last part na ni guys. Okay. So, microscopic analysis of urine is subject to several procedural variations, including the methods by which the sediment is prepared, pwede sad ang volume of the sediment examined, and the methods and equipment used for visualization, and the manner that they are reported. So, it is very important na as a laboratory, dapat standardize ato ang pag-reporting. As much as possible, we have to reduce errors para sa dili ta maglibog. Alright? So, microscopic examination, as what I've said, is the third part of routine urinalysis after physical and chemical. Okay, so it is the microscopic examination of the urinary sediment. Its purpose is to detect and identify insoluble materials present in the urine. Okay, so the blood, kidney, lower genitourinary tract, and external contamination all contribute the formed elements of the urine. This include RBCs, white blood cells, epithelial cells, casts, bacteria, yeast, parasites, mucus, your sperm, crystals, and artifacts. So it involves the identification and quantification of the elements present to determine the clinical significance. Because some of these elements, guys, some of these formed elements are of no significant are no clinical significance siya. So, they are consequently considered as normal unless they are present in increased amount. Therefore, the need for the quantitation. Okay? Alright, so microscopic examination also has your macroscopic screening. So this is to enhance the cost effectiveness of UA. Many laboratories have developed protocols whereby microscopic examination of the urine sediment is performed only on specimens meeting specified criteria. Alright, so labi na sa mga hospitals or labs na wala kayo gamit or short on equipment, dili sila usually nag-microscopic exam unless ma-meet nila ni na mga criteria. Alright, pwede pod sa uban na baling daghana kaayo na patient sa usa ka hospital, dili na makater tanan na i-microscopic, so pilian lang jud, okay? So during sa akong internship sa what do you call this, Perpetual and Chongwa. Chongwa is a very big hospital. So, ang ilahara jong microscopic exam kay katura jong kuan medyo weird bitaw iyahang results sa iyahang chemical exam and sa iyahang physical exam. So, ana lang. Alright, so mo ni ang screening test. So, we look for the color. So, iyang significance ani ang blood. Clarity kay imong hematuria or hemoglobinuria or myoglobinuria. And then this will also confirm pathologic or non-pathologic cause of turbidity. We also have blood, so its significance is your RBC and Rbc Cast. We also have protein sa inyong cast kay as we will further discuss later on na ang cast manggod, their primary constituent is a protein. Alright, so nitrite imong bacteria or WBCs, your LE, so mo ni inyong WBC, WBC cast, bacteria, and lastly, your glucose, your kuan siya, your yeast, more specifically your Candida albicans. Alright, so next, we'll proceed with the specimen preparation. So first off, you need to use, of course, a fresh or adequately preserved urine specimen. Diba, as we discussed in the previous lectures, wala may perfect na, what do you call this? Wala perfect nga preservative, pero ang usual na ginagamit kay ang refrigeration. Alright, so formed elements primarily RBC, WBC, and Hyaline Cast disintegrate rapidly, particularly in dilute alkaline urine. So, dapat di nato ni patudtuuran, not longer than 1 to 2 hours, dapat i-read na nato ang urine. Okay, so warm refrigerated specimens to 37 degrees Celsius or your room temp, and then use a midstream clean catch specimen, of course, because it minimizes external contamination of the sediment. Alright, and then we have to thoroughly mix specimens before decanting into tubes. And then, mo ni ato ang specimen volume. We have 10 to 15 ml, pero usual na itong ginagamit is only at 12 ml, okay? And then, its centrifugation, its duration is 5 minutes siya, guys. And then with a speed of 1,500 to 2,000 RPM or your revolutions per minute. And then if RCF inyong gamiton, your relative centrifugal force, 400 siya, okay? So as much as possible, guys, the length of the time the specimen is centrifuged must be consistent. Dapat kuan na jud kanang if 5 minutes ang ginakuan sa lab, 5 minutes jud siya, dili siya mo lapas, okay? And then do not use the braking mechanism kay di ba na major times na kanang dili ta kahulat, ganun. So kuan kanang as much as possible hulaton na jud nato, guys, okay? Na mo stop ang centrifuge kay ma-disrupt man ang imuhang sediments ana na form. So inyo siyang ikalit og stop, ma-shake na pud niya to, magbalik na pud niya kag kuan centrifuge. Okay, so its calibration is the tachometer kanang naa sa picture. So mo ni ang tachometer is an instrument measuring the rotation speed, okay, of a motor sa ato ang centrifuge. Okay, so sediment preparation and volume. So to maintain a uniform sediment concentration factor, urine should be aspirated off rather than poured off. Pero kuan man, usually ginagamit nato kay ang poured off technique lang jud kay kuan man nabe uban na labs na dili dato, so wala tay mahiyuana. Okay, so muni ato ang ginagamit sa pagkuha sa urine decantation method or your pipetting out. Kani siya na volume ato ang expected is your 0.5 ml urine. Okay, so lantaw nato sa picture, ang left is urine after centrifugation. Okay, so nana na mga formed elements dira sa ilalom. And then right is your urine sediment with residual urine after removal of supernatant. So more or less inana kadaga na ang kailangan nato. Okay, so sediment volume examined is around 20 UL or 0.02 ml, and then if mo ni siya if ginagamit na to ang conventional glass slide method. So after getting the volume we have here, we resuspend the sediment by gentle agitation lang jud siya, guys, with the koan kanang sa imuhang tube, gentle agitation, dili vigorous, guys, kay koan kanang para dili maguba or ma-disrupt ang ato ang ubang cellular elements. Okay? So, next we have your sediment examination. So, we use the bright field microscopy, and then we read under more or less 10 fields. We use the objectives, your LPO and HPO. So, we have to use LPO first to detect your cast. Kay, mo na siya kuan kanang ginagamit nato because kuan usually manggod if ang cast they are highly refractile. So we use LPO, dapat pahinayan gamay ato ang what do you call this, ato ang light para maklaro nato ang cast. And then siya pud atong iyon ang identify kay dali man gud siya mo disintegrate. Okay, so if nalibog mo sa cast, turn to your HPO na. Okay, so one thing about cast is they tend to locate near the edges of the cover slip. So, pag butang ninyo sa urine, dapat scan sa ninyo, lantaw mo sa edges if naabay presence of cast, okay? So, if sometimes manggod, if magkuanta sa urine, if limpyo ra kayo ato ang urine, we usually have a hard time focusing kung sakto ba ni na field akong gilantaw, ana. So, one thing you can do is use an epithelial cell as your point of reference, okay? When you are having trouble focusing, use epithelial cell. Okay, so we have your microscopic examination, your sediment constituents. We have a lot actually. So we have your cells, your cast, your crystals, and other structures and artifacts or your contaminants. Okay, so first we'll discuss your cells. So daghan pud kitang cells, they are subcategorized under blood cells, epithelial cells, microorganisms, and lastly your spermatozoa. Okay, so we'll discuss them one by one. First is your red blood cells. So they measure approximately pila. Okay, so they are approximately 7 mm in diameter. So they are identified using our HPO. So we identify your red blood cell using your HPO and we report them as your average per HPF. Okay? So um we have different types of blood cells manggod if koan kanang depende sa pH sa urine or unsa ba. So here we have your shadow cells. So these shadow cells are faint and colorless circles, whereas your crenated cells are small. They are rough cells. They appear crinkled. This is because of your hypertonic urine. So crenated because they shrink due to loss of water. All right. Another thing is your ghost cells. So they are lysed. Empty cell membranes na lang ni siya, guys, can be found in your hypotonic urine. So, ang ghost cells, man good guys, they absorb water. So, they swell, thereby malaisia, consequently releasing your hemoglobin, leaving only your cell membrane, okay? And then we have your dysmorphic RBCs. So with protrusions ni siya, guys, or fragmented, so it appears to be an acanthocyte, okay? So, di ba? Ato ang laing name sa acanthocyte kay... Okay, so your Spur cells. Okay, so kaning red blood cells nato, guys, they are very difficult to recognize because of its lack of characteristic structures, variation in size, and daghan pud siya kaayong kuan, parente ug nawong. So they have a close resemblance to kaning yeast cells ninyo, inyong oil droplets, and your air bubbles. So ang normal values na makita nato ani kay is around 0 to 2 or 0 to 3 cells per HbF. Okay, so its significance is renal disease, lower urinary tract disease, your extrarenal disease, toxic reactions, and physiologic causes. So as you can see, they are usually associated with damage to the glomerular membrane or pedicel vascular injury within your genitourinary tract. Okay? So, moni ato ang nawong for our normal RBCs. As you can see, lisod jud siya, guys. Lisod siya ma-pinpoint. Even ako pod maglisod pud ko og identify og RBCs katong nag-work pa ko sa lab, okay? So, kani we have your microcytic or your crenated RBCs. Kani mo ninyong normal RBCs. Dysmorphic RBCs kana inyong fragmented. So, kani guys, they can be mistaken to yeast cells kay lantawa mo siya pari-pares og size. Pero one thing you have to know, kay ang yeast cells, they show budding, manggod, gabud sila. So, if makakita mo, nagatapok-tapok na siya, gabud na siya. So, yeast cells siya. Okay, so pwede sad siya oil droplets, pwede pod air bubbles. Pero, ang nakakuan ani niya, these oil droplets, these air bubbles, they are highly refractile when your adjustment knob is focused up and down. So, muna siya one thing to distinguish nila. Okay? Next, we have your WBCs. First up, we have your neutrophils. So, its appearance is granular with multi-lobe nuclei. Neutrophils or your WBCs are larger than RBCs, about 12 mm in diameter. So, 7 mm raman si RBC, di ba? So, predominantly, ang neutrophils natong ang WBCs natong makita is your neutrophils, okay? Because they are easier to identify. Because of their granules and multi-lobe nuclei, okay? So they have 3 to 4 lobes, di ba? Ang ato ang koan, ato ang segmented neutrophil, okay? using your Sternheimer-Malbin stain. Alright, so another variation of your neutrophil is your glitter cells. Swollen WBCs exposed to hypotonic urine. And then glitter cells have no kuan manggod pathologic significance. So we also have your Brownian movement of granules. Okay, identification error can be mistaken as your RTE cells. Normal value ranges from 0.5 or 0.8 cells per HPF. Its clinical significance, of course, is infection or inflammation of the genitourinary tract. Okay, so mo ni ang ato ang nawong sa inyong neutrophils, mo ni. Okay? So next up, we have your eosinophils. So eosinophils, man good guys, are not normally seen in the urine. Therefore, bisag kuan lang guys, bisag 1% lang ang inyong makita, they are automatically considered significant. Okay, so we stain them using your Hansel stain or pwede sad ang right stain. Okay? So its clinical significance is if present ni siya, maybe because of your drug-induced interstitial nephritis, okay? That is the kanang primary reason. And then UTI, pwede sad, renal transplant rejection, okay? So muna atong eosinophils, okay? Tanawan na siya mga granules there. Okay, next we have your epithelial cells na guys. So these epithelial cells, they are derived from the linings of the genitourinary system. So it is not unusual to find them, okay? Dili ta mas may if natay makitaan dayon. Unless if makita nato sila in large amounts, increased amounts, so or in abnormal form. So dila na ta mas may. Okay? First up, we have three types. So we have your squamous, your transitional, also known as your urothelial cells, okay? Recall lang sa inyong what do you call this? Unsa to pangalan tong sigig drawing bitaw guys na subject? Second sem ninyo last year. Tesa nalimot ko guys. Ako ba nang gitudlo? Medical histology, okay? And then, akapuyo. And then we have your renal tubular. Okay, so again, three types. We have your squamous, transitional, or also called as your urothelial, and then your renal tubular cells. Okay, there are kaning ato ang epithelial cells. They are classified according to the site of origin. First up, we have your squamous epithelial cells. So its appearance is the largest cell, abundant, irregular cytoplasm with prominent nucleus. Okay, so as what I've said kanina, can be used as your point of reference if nalibog mo sa inyong pag-focus sa inyong microscope. Okay, so kani ato ang mga squamous epithelial cells, they originate from the linings of the vagina and pwede sad sa atong female urethra or sa lower portion sa male urethra. Okay, so appearance of this or unsay tawag ni presence of this is usually due to the normal slowing and have no pathologic significance. And kuan po day guys, ang glitter cells have no pathologic kuan po guys, have no pathologic significance, okay? And then so kaning ato ang mga your squamous epithelial cells, they are usually increased amounts are more frequently seen in your female patients. Okay, so identification error, we have your folded cells kay pwede siya mo resemble og cast. And then koan your epithelial cells, your squamous epithelial cells, no clinical pathological significance. Pero pwede siya mahimong clue cell. So these are your epithelial cells covered with your Gardnerella vaginalis coccobacilli, or this is indicative na siya guys of vaginal infection. So one thing I use to memorize your Gardnerella vaginalis, ako ang giuse ana na mnemonic is your gardener is looking for clues, okay? Mana siya si gardener nangita og clues mo na siya. Kamo guys, if mo work na ninyo, okay ra pod kayo. Share ako. Okay, so all right, so it is reported in terms of your rare, few, moderate, or many, okay? Later on mohatag ra sad kog mnemonic ninyo para unsaon ninyo pag dili mo maglisod sa inyohang reporting. Okay? So we have here under LPO, under HPO, kailan naman mo ani niya. And then next we have your urothelial cell, your transitional epithelial cell. Okay? So they line the renal pelvis, calyces, ureters, bladder from the upper portion of the male urethra. They are seen singly, in pairs, or in clumps, also known as your syncytia. Okay, so its appearance is spherical, polyhedral, or caudate with a tail-like appendage with centrally located nucleus. Okay, so lain-lain siyag nawong guys si transitional, of course kay transitional naman siya, all forms have a distinct centrally located nucleus. So mo yung take note, centrally located nuclei, okay? So identified, they are usually identified using your high power objective and reported as your rare few, moderate, many, okay? So identification error, we have your spherical forms resemble RTE cells, and then or your renal tubular epithelial cells, and then its clinical significance, increased numbers with abnormal morphology may indicate malignancy or viral infection. Okay, so one way to aid identification sa inyong transitional is by the use of your supravital staining. Okay, so mo ni siya. Polyhedral, lahi-lahi siya, spherical. We have your caudate, katong na ay appendages. Syncytia, okay? Catheterize ninyo. Okay, so lastly, sa inyong epithelial cells, we have your renal tubular epithelial cells or your RTE cells. So, appearance nila, they vary in size and shape depending on the area of the renal tubules from which they originate. Pwede sila rectangular, columnar, round, or cuboidal with an eccentric nucleus, guys. Okay, eccentric nucleus. Kuan ninyo, transitional centrally located. Okay, so possibly bilirubin stained or hemosiderin laden. Okay, so RTE cell from your proximal convoluted tubule or your PCT. They are rectangular, columnar, or convoluted cells. They are larger than other RTE cells and are coarsely granular sa inyong cytoplasm, okay? So, inyong DCT or your distal convoluted tubule, it is round or oval, okay? Basta distal convoluted, round or oval, proximal, rectangular, and then si collecting duct, cuboidal, okay? CC, collecting duct cuboidal. Okay, joke. Kamuray bala, guys. Okay, so one thing to take note, ang mga RTE cells sa inyong DCT is smaller than PCT. And then, they are usually mistaken for Wbcs and spherical transitional epithelial cells. So, one thing to take note of that. Okay? So, muni identification error muni akong gingon. And then, its significant value is greater than 2 RTA cells per HPF. So, if greater than 2 na ganin yung makita, guys, kuan na siya kanang it is very important because it is indicative of tubular necrosis which affects kuan manggod overall renal function. So kuan we have to be kuan jud cautious in reporting, dapat sure jud ta, okay? So we have here your cuboidal RTE kani Persian blue stained siya. Okay, and then we have your another variation of your RTE cells. It is your oval fat bodies. So, ang oval fat bodies, oval fat siya. So, it contains lipid na RTE cells nimo. So, they are highly refractile and the nucleus are hard to observe. They are reported by average per HPF, okay? So, lipid stains include your Sudan 3 or your oil red O. So, orange-red droplets ang color sa mga neutral fats na to, okay? Polarized microscopy. If mo na itong ginayuse, we can see your Maltese cross. Present ni siya sa inyong cholesterol. And then its clinical significance is your nephrotic syndrome, guys. Always take note, oval fat bodies, nephrotic syndrome, automatic na siya. Okay? So, mo ni siya akong ginaingon na kuan, ato ang oval fat bodies, di ba, lisod makita ang atong nuclei anam, akalibog. Okay, mo ni akong gingon na Maltese cross, okay? Alright, so next up we have your bacteria. So its appearance is small, spherical, pwede rod shape, okay? Normal na jud atong bacteria in urine, guys, okay? They multiply rapidly at room temperature for extended periods of time, of course, naman, di ba? But if inani man gani mo multiplier siya because of na standard jud siya for way too long, dili siya important, wala siya significance, okay? So identification error may be because of your can be mistaken for your amorphous phosphates and your urates, okay? So its clinical significance is with your UTI. So to confirm if UTI jud siya, dapat na sad tay makita na WBCs, okay? Kay if wala siya WBCs, maybe because na standard siya for too long, okay? So this bacteria may produce positive nitrite in a pH above 8, indicating an unacceptable specimen. Okay? If mo na gani na-stand na siya for too long, they may produce, and then matest na siya, they will produce a positive nitrite in a pH above 8. Okay, so unacceptable na siya, guys. Okay, and then these bacteria are reported using your rare few, moderate many per HPF. Okay, so just a quick side note: the bacteria most frequently associated with UTI are your gram-like rods, also known as your Enterobacteriaceae. Okay, your Enterobacteriaceae. And then, pero dili siya mo limit na pod sa inyong Enterobacteriaceae. Nasa tayo mga cocci, di ba? We have your Staphylococcus and your Enterococcus, okay? They are also capable of UTI, okay? Next, we have your yeast. So, appearance niya it is small, oval, refractile structures with buds and or mycelia. So, kani, as you can see here, mo ni iyang mycelia, kani mga strands. Sa kuan ninyo, as you can see here, makita jud ninyo na mura jud siya RBC if wala lang jud siya nag-show og budding, okay? So, of course, its clinical significance, yeast infection. So, to confirm if it is really yeast infection, must have the presence of your WBCs, okay? So, primarily, Candida albicans are seen in urine of diabetic patients, immunocompromised patients, and women with vaginal moniliasis, okay? Reported, again, they are reported via rare, few, moderate, many per HPF. Alright, that's how you report your yeast. Next up, we have your parasites. First off on the list is your Trichomonas vaginalis. So its appearance, we all know na, pear-shaped, motile, flagellated trophozoite. Okay, so its identification error may be WBC or RTE cells. Pero if motrophozoite na siya, um, it becomes non-motile na, okay? So its clinical significance, of course, is your trichomoniasis or your STI because we all know Trichomonas vaginalis is a sexually transmitted pathogen, okay? This is usually associated with vaginal inflammation. And it is, kani ato ang kuan diri, Trichomonas vaginalis is easily identified in wet preparations of the urine sediment. So, one thing you take note of it is its rapid darting movement, okay? Rapid darting movement, see Trichomonas vaginalis. So, report it as rare few, moderate many per HPF. Okay, so, na ako'y gi-upload na files, guys, sa Google Drive. Before ko work ani na SEM karon, during the break, I was working in a lab diri sa Amua. And then, na ako yung mga pictures dito gibutang na luoy kaayo. One picture, those pictures there, guys, represented um, a lolo siya, okay? A patient, an old patient, male, um, gi-catheter siya. So, kato siya na urine, ako ang gikuha, ako ang gi-examine is from a catheter. So as you can see, presence of infection, kay daghan kaayo paglantaw na ako microscopic, boom, daghan kayong WBCs, too many TNTC na to siya, guys. Okay? Kanang unsa na too numerous to count. So wala na ko laing makita sa microscopic field. And then why am I chikahing this guy? That video there, nag-upload ko dito video. Um luoy kayo guys because dili ako ang nakakita ato guys, ako ang colleague. A 14-year-old female patient came in saying na kuan halang iyahang vagina, sakit daw ipangihi, like mura daw gibutangag jufram na hot sauce iyang vagina. And then pagpangihi na didto guys, sa video inig-play ninyo makita dito sa inyong lower right dapit na adjud gamay kayo guys na kuan dito Trichomonas Vaginalis. So dili kayo maklaro iyang undulating membrane kay kuan kanang medyo nadugay ko ato kay gikan ko nag-ward. So ayha na ko nakabalo pag abot na nako gikan ward. So naluoy ko kay kuan di ba sexually transmitted man, 14-year-old ang patient na babayi, and then kuan kanang patient history confirmed na she was a rape victim by his uncle, di ba? Like murag whew, what a day, as in like luoy kaayo si baby girl. Okay, so wala lang murag naluoy lang ko ba kay kuan siya nang gani nang galisod, girape pa siya, napa siya kaning STI. So grabe guys. I hope makita ra ninyo sa kuan sa video ang kuan ang Trichomonas vaginalis. Okay? So all right, so much for that. Let's proceed with your other parasites. Next up we have your Schistosoma Hematobium, your oval shape with terminal spine, okay? And then lastly your Enterobius vermicularis ova or your D shape. What do you call this? Your D-shaped parasite, diba? Ang iyang ova. Kay katong murag flat on one side, diba? Okay? And then curved on the other. So, if for example, makita mo Enterobius vermicularis, it is usually because of your contaminated ang urine with fecal or feces. Okay? Next, we have your spermatozoa. Okay. So, wala na ko'y daghang patumpik-tumpik pa. So, its appearance, tapered oval head with long thin tail. Okay? Murag maklaro ram guys sa picture. Okay? So, its identification error, wala. Kay very unique. Joke. Okay? So, its identification error, wala. Kay very unique. Kay ni spermatozoa, unang kita nimo, boom, sperm. Okay? So, urine is toxic to urine is toxic to sperm. Therefore, they rarely exhibit motility. Okay? So, paglantaw na to sa ato ang gi-prepare na urine, makita na to na wala na siya naga-move or gamay na lang restricted movement na lang ato ang mga sperms. Okay? Alright, so much for that. Yes, let's go. Kuan na, cast na ta, cast. So, daghan pud kaayong cast, guys. We have your Hyaline Cast, cellular cast, guys. Basically, kuan ni siya kanang inyohang mga cells na kuan bitaw kanang daghan na kaayo, and then kuan na ay something wrong sa imuhang genitourinary system. So, magkahimo-imo na siya og cast tungod sa kadaghan, okay? We have your fatty cast, granular cast, mainly from your course, from your Rbc or Wbc cast, okay? And then they can be subdivided into coarse granular or finely granular cast, okay? And then lastly, we have your waxy cast, and lastly your broadcast, okay? All right, so casts are the only elements found in the urinary sediment that are unique to the kidney. Guys, please ayaw ninyo nigkalimti, bahalag malimtan ninyo inyohang kuan pamahaw. Char, ayaw mo kalimutog pamahaw, guys. Bahalag malimtan ninyo ang pangalan sa imong crush, basta ayaw ra ni char. So si casts are unique to the kidney. They are formed within the lumens of the distal convoluted tubules and collecting ducts. Okay, so appearance nila tubular, with parallel sides and somewhat rounded ends. So they represent the shape of the tubular lumen. Okay, may contain additional elements in the filtrate such as cells, bacteria, granules, pigments, and crystals. Okay, so its main composition, protein siya guys ha. It is your thumb horsefall protein or your uromodulin. Okay, your uromodulin. Okay, so these casts are reported average per LPF siya, okay? And these casts have a low refractive index. So, normal excretions of uromodulin, manggod guys, is at a constant rate. So, Yeah, normal jud siya, and then they will usually increase under conditions of stress and exercise. So mutaas na siya because of stress and exercise. So presence of urine in presence of cast in the urine is your cylindruria, okay? So, mani siya akong giingon na we have your cast and your cylindroid. So, the difference, so ang cylindroid nato man guys, it is similar to cast pero tapered ends siya, okay? So, it forms in the ascending loop of Henle and your DCT. Whereas, inyuhang cast man good, tubular jud siya guys with parallel sides, sometimes rounded, and nagform ni siya sa imuhang DCT, distal convoluted tubule, and your collecting duct. Okay? That's the difference between your cylindroid and your cast. Okay, so hyaline cast. First, we'll discuss your hyaline cast. Its appearance is colorless, homogeneous matrix. Okay, consists almost entirely of uromodulin. Okay, so it has low refractivity. So its refractive index is the same as urine. So kuan lang jud guys kanang careful lang jud ta ani okay kay basin pag ana nato wala pero naadi ay oh di ba ganun wala pero naadi ay okay. So, identification error, pwede mucus threads, fibers, hair, or increase lighting. Okay? So, muna akong gingon, dapat pahinayan gamay ato ang lighting. Okay? Normal values, usually 0 to 2 per LPF. Alright, so its clinical significance may be because of your glomerulonephritis, pyelonephritis, or your chronic renal disease. Pwede sad inyohang, take note guys ha, congestive heart failure, stress, and exercise. Okay, so quick side note lang guys, kadyot lang, your S hematobium, so its clinical significance may be due to hematuria or pwede sa bladder cancer. Okay? So, okay, back to hyaline cast. So, as you can see here, stress and exercise. So, one thing to take note guys, basta stress and exercise, muni ang mga cast na present. We have your hyaline cast, and then your, wala lagi siya. We have your hyaline cast, your Rbc cast, and your granular. Okay? Ako siya na guys. Granular. So, basta, nawala. Ay, basta, basta stress and exercise gani guys. Hyaline cast, Rbc cast, granular cast. Okay? Mora ng tulo. And then, one thing to take note, basta hyaline cast, siya, congestive heart failure. Okay? So, if you stain hyaline cast with Sternheimer Malbin, it stains with a pink color. Ano siya? Okay, next we have your Rbc cast. So, Rbc cast, its appearance is of course, cast matrix with RBCs. Pwede orange-red color indicates bleeding within the nephron. So, Rbc cast, specific for bleeding in the nephron. Identification error, Rbc clumps. Makita tag mga clumps dito na RBC, pero walay, kung ano siya, ang nakalahi kay walay cast matrix ang atong Rbc clumps. Clinical significance, glomerulonephritis or your strenuous exercise. Sumutong gingon, stress and exercise, hyaline, Rbc, granular cast. Okay? So, next up, we have your Wbc cast. So, same, cast matrix na Wbc. So, its clinical significance is due to pyelonephritis or your acute interstitial nephritis. So, infection or inflammation within the nephron ang WBC cast, RBC cast, bleeding sa nephron. Okay, so when we talk about pyelonephritis, of course, we refer to it as your upper UTI. Okay, pero ang cystitis, 'di ba, ang lower UTI. Okay? So, next ni RBC cast. Okay. All right. WBC clump. Tanawa, wala siya klaro kay yung matrix guys, dili siya kanang kuan jud. Di siya inani ba? Nana di siya clear edges. Ana. Okay? All right. So next we have your epithelial RTE cell cast, okay? Appearance same ra Japon. RTE cells with a protein cast. Identification error maybe because of your WBC cast. Clinical significance is your renal tubular damage. All right. So we have here pictures. Kani RTE cell cast, di ba? Mura siya pare-parehas og kuan, WBC. Alright, next we have your fatty cast or your fat droplets, okay? So, fatty cast is ang iyahang appearance ani are your fat droplets or your oval fat bodies. 'Di ba? Atong oval fat bodies, recall your RTE cells pero it contains lipid, 'di ba? Okay, so attached to a protein matrix. Identification error, fecal debris, okay? All right, fecal debris ang iyang identification error. And then one thing to take note is your fatty cast, same as your oval fat bodies, they are highly refractile. Okay, and then confirmation ani guys, we use your polarized microscopy. And then we stain this using your same Japon Sudan 3 or your oil red O fat stains, okay? So fats do not stain with Sternheimer-Malbin. Take note ha, fats do not stain with Sternheimer-Malbin. Okay, clinical significance, nephrotic syndrome, toxic tubular necrosis. We have your DM and your crush injuries. Diba? Sana all crush. Charot. So, we have a note here. Fatty cast should be accompanied by other lipid elements and proteinuria. So, muni ang characteristics nato of your nephrotic syndrome. Okay, so mani siya itong picture. Okay, next we have your granular cast. So, its appearance is a coarse and fine granules in a cast matrix. Kay, di ba, atong granular cast subdivided into what do you call this? Subdivided into fine, diba, or coarse granular cast. Okay? So, identification error, clumps of small crystals, pwede sad columnar RTE cells. So, clinical significance, take note, glomerulonephritis, pyelonephritis, and again, nasad si stress and exercise. Okay? Stress and exercise, granular, Rbc cast, o hyaline cast. Okay? And then, sorry guys. Balik na buta. Sorry. I forgot to mention this sa inyohang WBC cast. Alright, so di ba we have your pyelonephritis. So imuha ni siyang upper UTI. So di ba usually sa kidney ni siya. So we this as your naa siya WBC cast, naa siya WBC o na siya bacteria, okay? Complete siya sa tulo. Alright? Sa inyuhang cystitis, so inyuhang lower UTI, so nani siya usually sa inyong bladder or ureter, naa siya WBC, naa siya bacteria, pero wala siya cast. Kaya di ba cast naman siya sa upper na kanang sa tawag ni ginahimo, okay? And then lastly, we have your acute interstitial nephritis. So this is usually drug related ni siya, allergic reactions, guys. So kani we have your WBC cast pero wala siya bacteria. And mo na siya WBCs, cast, and your bacteria. So, kani siya si acute interstitial nephritis. Ang naara niya kay WBC cast o bacteria. Okay? So, just a quick side note ito siya, guys. Nakitaan ako sa akong notes during review. Okay? So, next up, we have your Waxy cast. Okay? So, Waxy cast, so they are highly refractile cast with jagged ends and notches. Sana. So, its clinical significance is stasis or your stoppage, slowing of urine. Chronic renal failure. So, kuan siya guys, chronic renal failure, stasis of urine flow, si imuhang Waxycast. Okay? And then, kanina jud ang pinaka, kani, mo ni ang finely granular, coarse granular, waxy. Okay? Alright? So, mo ni siya guys, ang pinaka kuan na jud, pinakagrabe. See, broadcast your these are also called as your renal failure cast. O, di ba? Grabe kay siya. So, all types of cast, guys, all types of cast may occur in the broad form, in this form. Pero, ang most common na mo-occur are your granular and waxy cast. So, these are commonly seen. So, clinical significance, okay? Of course, your extreme urine stasis and your renal failure. Alright? So, mo ni ang inyuhang broadcast. Okay? Next, next we have your crystals na. So crystals, subcategorized into normal crystals and abnormal crystals. So one thing to take note, guys, abnormal crystals are found in acidic urine. So kuan usually kining abnormal jud, guys, acidic urine. Okay. All right. So crystals are formed by the precipitation of urine solutes, including inorganic salts, organic compounds, and medication. So inyong iatrogenic compounds. Okay. So its appearance is geometrically formed structures or amorphous material, so without a clear defined shape or form. So the primary reason for the identification manggod aning imuhang urinary crystals is to detect the presence of kanang mga few abnormal types nato that may represent diseases. So example ani, we have your liver disease, we have your inborn error of metabolism, pedicid renal damage caused by the crystallization of medications, okay? Kanang kuan na dugay na nag-medicate ani na kuan substance, okay? And then these crystals are reported rare few, moderate many Japan or your RF MoMA per HPF, okay? This is your sa inyohang normal crystals. Pero if abnormal siya, guys, average siya, okay? Average per LPF, okay? So again, RF MoMA or your rare few, moderate many per HPF, C normal crystal, C average per LPF, C abnormal crystal, okay? So factors affecting solubility. We have first your temperature. So solutes precipitate more readily at low temp, of course. Therefore, majority of crystals takes place in specimens at room temperature or have been refrigerated before testing. Okay. So next factor, we have your solute concentration. So as the concentration of the urinary solute increases, their ability to remain in solution decreases. So it results in your crystal formation. And lastly, your pH. So it determines the type of chemicals precipitated. So naman tayo makita ng mga kuan, what do you call this, crystals na nasa alkaline urine, and then napo tayo makita na crystals na makita nato sa acidic urine, okay? Alright, mani akong gingon. So kani siya, guys, sa kuan pa ni siya normal pa ninyo na crystals, okay? Normal crystals. So, si uric acid, amorphous urates, calcium oxalates, sa inyohang acid, amorphous phosphates, calcium phosphate, basta anything na phosphate, alkaline na siya, guys, or neutral, calcium carbonate, ammonium biurate, so muni, alkaline Japon, okay? So, first up, we have your uric acid. Sa inyo ni siyang acidic urine, okay? Its appearance is rhombic, four-sided plates, whetstones, wedges, and rosettes, okay? Color niya kay yellow-brown, okay? Its clinical significance is your leukemia, pwede sad ang inyohang Lesch-Nyhan syndrome, and your gout. So, this uric acid can appear in pH that is lower than 5.5. O, diba? Grabe kayo siya. Grabe kayo siya, okay? So, lower than 5.5, it is highly bifringent under polarized light, which aids in muna siya. So they are highly bifringent under polarized light, which aids in distinguishing them from cystine crystals, okay? So next up, we have your amorphous urates. Amorphous urates, still in your acidic urine, appear microscopically as yellow-brown granules observed in refrigerated specimens. So brick dust or yellow-brown iyahang color, pero, di ba, nag-mention man ko na if ever gani ma-refrigerate gani ang atong specimen, natay makita bitaw na murag pink color, di ba? Ang pigment ani kay ang ato ang uroerythrin, okay? So good. So kani atong amorphous urates produce a very characteristic pink sediment, okay? If it has been refrigerated, this is because of your uroerythrin na pigment. Joke. Okay? So next we have your CaOx, your calcium oxalate. So its appearance, duwa ni siya, guys, na atay monohydrate and dihydrate. So si dihydrate ang most commonly makita na to. Makita na siya as your envelope. So kani na middle picture. Kani ato ang calcium oxalate na dihydrate. And then its color is colorless, of course. Clinical significance, it's your ethylene glycol poisoning. So basta ethylene glycol gani siya guys, mo ni inyong dumbbell or your monohydrate. Okay guys, if fresh gani na urine atong makita, like fresh urine atong gitest. So if makakita tag clumps gani guys, clumps of your caox, this may be because of your nagkay-nahinay form o renal calculi ato ang koan ato ang body, okay? Kay nga naman ma'am, because your calcium oxalate, your CaOx is the major constituent of your calculi, okay? So take note, if fresh urine gani pagkita na, if fresh urine paglantaw nato daghan kay siyang clumps of CaOx, possible na magka kidney stone si patient or undergoing kidney stone kuan siya, okay? Next, we have your, kung ano siya, alkaline urine na ta, guys. So, if alkaline urine, si amorphous phosphates na nato diri. Okay, kay acidic, kay si urates man. Appearance, granular, same ra Japon, pero yung color kay white to colorless. Alright? So, muna iyahang nawong. Okay, very common. Then next, we have your calcium phosphate. So, not frequently encountered. They are seen as your flat rectangular plates or thin prisms, often in rosette formation. Okay, so, kuan Japon guys, wala Japon siya color. Okay, triple phosphate, your kabaong, or also known as your coffin lid. Pero if mo disintegrate ni siya guys, they will leave a feathery appearance. Okay, clinical significance, none. Pero, it is usually associated with urease producing bacteria. Alright, calcium carbonate, dumbbell or spherical shape may occur in clumps. Okay, ammonium biurate or your thorny apples. Okay, almost always encountered in old specimen. So if makakita mo ammonium biurate, automatic old specimen na urine na gihatag ni patient. Okay. So next we have your abnormal na ta guys, abnormal crystals, okay? So as you can see here, ang pH niya acid jud. If dili man gani acid neutral, wala jud alkaline, okay? So first we have your cystine, okay? So this cystine, its appearance is thin or thick hexagonal plates, colorless Japon siya. Muni akong giingon na inborn error of metabolism, so clinical significance inherited cystinuria if naa si cystine. They have a tendency to form renal calculi or your kidney stones, particularly at an early age. So, luoy kayo si patient if ever naa siya ani, okay? Sainan ka, bata pa ka na nakikuan kidney stones. Luoy ya, oy. So much for that. We have your cholesterol, okay? Appearance, rarely seen unless urine is refrigerated. Rectangular plate with notch na po siya, guys. Notch corners, okay? Mara siya mga buak-buak na mga glass slides. Clinical significance, again, nephrotic syndrome, okay? Take note ha, nephrotic syndrome. Kabantay mo mga usually nephrotic syndrome katong mga associated yan kay katong mga fat bito na yung mga fat, okay? So one thing to take note na. Okay, kay atong cholesterol man good na crystal seen in conjunction with fatty acids and oval fat bodies, di ba sila ang significance man pud nilang duwa kay ang nephrotic syndrome. Alright? Next, we have your ako ang giingon pud ganihan na liver disorders, di ba naman tayo mga liver disorders. And then makita nato ni sila na mga crystals dito. Tulo ni sila kabok guys, si leucine, si tyrosine, o si bilirubin. Tulo na sila guys, okay? If naa ni sila, automatic positive ang chemical reaction sa bilirubin, okay? Sa chemistry. Alright, so si kani si leucine ug si tyrosine guys, oh my gosh, sila ang manag-uyab, okay? If naay manag-uyab sa klase, sila manag-uyab sa urine char. So sila sila ang manag-uyab guys, kay nga naman I'll explain that later, okay? So si leucine, this appears as a spheres that could demonstrate concentric circles and radial striations. So kani makita ninyo ni na siya mga striations dira, okay? Circle siya. And then it's yellow kay yellow or yellow brown. Muna siya liver disease, okay? Kay what do you call this? Next wait ha. Mo explain na ko later on. Ngano sila man naguyab. Okay? Si tyrosine nimo, as you can see here, fine needle siya guys that form clumps or rosettes. So colorless to yellow siya, liver disease Japon. Okay, so si leucine manggod ninyo guys, it is less frequently seen than tyrosine. Okay, but if present, must accompany tyrosine crystals. Okay? And then, ang nakakuan pod ani ni tyrosine, if present si tyrosine, it is seen in conjunction with leucine and mo na ang gingon have a positive result for bilirubin. So one cannot be present without the other. Char mo na siya. Mo na siya. So if nasi leucine, nasi tyrosine. If nasi tyrosine, dapat nasi leucine. Okay? And then, si bilirubin, inyohang kuan, supportive friend, inyohang third wheeler. Alright, si bilirubin, ang inyong third wheeler, seen as clump, needles, or granules. Of course, bilirubin man, color dyan niya kay yellow. Alright, so, so much for that. Liver disease ha, tulo ka buok, bilirubin, leucine, tyrosine. Okay? Alright, next we have your sulfonamides or your sulfa drugs. Appearance nila kay fine needles Japan guys that form clumps or rosettes. So, as you can see, di ba nabantay mo na dagan kayong mga fine needles or kanang pari-pariho sa bitag nawong. So that is why it is important jud na we know the chemical part of the urine kay pwede man ta maka-rule out sa ato ang mga findings sa ato ang mga kuan sa ato ang patients, all right? And then most especially sa pH and then sa ilang pong kuan physical exam sa ilang color ana di ba, so these three parameters they work hand in hand jud siya guys. Okay, all right, so much for that. Clinical significance, infection treatment. Okay, so these sulfa drugs we have to check for patient's medication history to aid in the identification. Alright, next we have your ampicillin. Ampicillin, needles Japanese guys that tend to form bundles following refrigeration. And then, same Japon siya sa sulfa drugs, infection treatment Japon ang iyahang clinical significance. Alright, next we have your radiographic dye or your contrast media. So, its appearance is similar to cholesterol. So, its color is colorless. And then its clinical significance is your radiographic procedure. So take note, cholesterol crystals should be accompanied by other lipid elements and proteinuria, di ba? Akong gingon ganiha. And then the specific gravity of a specimen containing radiographic contrast media is markedly elevated. So greater than 1.04 ilahang what do you call this, SG when measured by a refractometer. Alright, so before ta mo proceed ani guys, nakoy gisend og picture sa ato ang virtual classroom, wala na ko siya na-attach kay bag earning na update. Okay, please open that. So we have here your crystals. Aro na guys. So mo ni ato ang crystals. Okay. So we have your renal lithiasis or your renal calculi. So may form in the calyces and pelvis of the kidneys, ureters, and bladders. Imuhang mga kidney stones. Okay. So small calculi may be passed in the urine. Kay kabantay mo guys, if manghita, kanang unsa ito gani, the normal passage, a normal way to excrete this kay tungod sa pressure gani sa pagpangihi nato, di ba, kay mangusog man ta medj, di ba, if manghihita. So mo na siya kay murag during the review naka-learn ko manggod na ang ato ang nagahimo jud siya crystals jud, pero it is small enough na dili siya significant and ma-washed off or like ma-excrete na pud siya tungod sa pressure na ato ang ginahimo if manghita. Okay, so large calculi guys cannot be passed and may not be detected until patients develop symptoms for urinary obstruction. Wala dili jud siya ma-zoom in, ay wait, or ako aning i-down, wait ha. Okay, there. May maklaro ra. So, its conditions favoring calculi formation are, of course, pH, okay, chemical concentration, and your urinary stasis or your stoppage of urine flow. Okay, di ba? As what I've said, normal excretion ani kay ato ang pagpangihi. So, if mo stop na, wala na flow atong urine, dili na ta ka excrete. So, ma-build up ang kuan dito, ang what they call these crystals, okay? And then one thing to aning large calculi is through lithotripsy. Okay, so this is a procedure using high energy shock waves that can break stones in the upper urinary tract into pieces that can be passed in the urine. So high energy shock waves na siya, guys. And then chika lang ko gamay, ako ang tita sa una na hospital siya because of kanang kidney stone, and then gioperahan jud siya, guys, and then we found kanang mga kuan, usa ka kinumo jud, guys, na kidney stone. Inana siya, grabe kayo, guys. So luoy kay akong tita na baling pagpaniwang niya, lisod kayo, sakit iyang luyo, sakit iyang buko-buko, iyang kanang back pain, inana, which is a symptom. Okay? And then, dili pud kay siya tig-inom og tubig. So, mo na tong na-develop dito, guys, ni grabe. So, we have here your primary UA finding, hematuria, okay? So, mo ni ang uric acid na calculi. We have your staghorn calculi, di ba? Sakita, di ganyan niyo. We have your cystine calculi and your calcium oxalate, di ba? Inyong primary constituent. Alright? So, during my internship days sa Perpetual Succor Hospital, na ako nakitaan na nagkuan sila ani na a patient na nagpa-examine sa iyahang urine, what do you call this, your kidney stone. So, that was weird and amazing. Kay guys, baho siya, as in legit baho ang ato ang crystals, guys, baho siya. And then what we did kay ang mga RMTs na mga ng time kay kami may gipadukdok ani sa mortar and pestle, and then mas kuan siya kanang as in grabe kaayo, baho kayo, and then gahi. Alright, so another chikara po to. So we have your types of renal calculi. We have your CAOX, uric acid, cystine calculi, phosphate calculi, triple phosphate calculi. Okay? So manilang description. CAOX, major constituent. Okay? Very hard, dark in color with rough surface. As you can see here, gabi kayo. Na siya mga spines, mga thorns. Okay? And then uric acid, your urate calculi associated with increased intake of foods with high purine. So yellowish to brownish red, moderately hard. Okay? Kani. Supper sa taas. Kani. Uric acid. Okay? And then cystine calculi seen in hereditary disorders of cystine, diba? As mentioned earlier, inborn error or sorry guys, as mentioned earlier, it is an inborn error of metabolism. Okay, so as what I've said, renal calculi formation can be produced within an early age. All right, so it is yellow, brown, greasy, and resembles an old soap. So it is the least common calculi. So, only 1 to 2% lang ni siya. Kay, seldom raman tong naay problem sa ilahang koan. Ano siya tawag ani? Cystine. Alright, so phosphate calculi, we have your pale and friable. So, it is a, phosphate calculi, we have your pale and friable. So, phosphate, pale, PP. And then, next, we have your triple phosphate calculi. So, it is accompanied by urinary infections involving urea splitting bacteria. So, muni ato ang mga staghorn. Okay? Kani, katong sakit kay ilang tawon. Diba? Si triple phosphate na siya, guys. Kani. Alright. And then, next, we have your, ang mga rare ni siya, guys. We have your sulfonamide, your silica. So, this is your ingestion of silica over a long period of time. We have your triamterene. So, insoluble diuretic ni siya, guys. Mustard-colored stones. We also have your adenine, so associated with inherited enzyme deficiency and hyperuricemia ang inyohang adenine. Lastly, we have your xanthine. So, it is associated with a genetic disorder with an absence of xanthine oxidase. Alright? Okay? So, let's proceed with your other structures and artifacts sa inyohang microscopic exam. So, usually, mga contaminants na niya, guys, or mga kuan lang, pa-extra lang. So, first up, we have your mucus threads. So, appearance is single or clump threads with a low refractive index. So, pwede niya siya ma-mistaken as your hyaline cast. So, while working sa lab, guys, I was having a hard time manggod aning hyaline, your mucus threads kay, mura siya kuan ra. kanang abi bitaw nimo wala siya pero paglantaw sa ako ang kauban kay daghan di ay ana. So I don't know kanang maglisod kog identify sa ato ang mucus threads. Pero one thing na giingon sa ako ang kauban asya na basta if nakay makita dira na hugaw-hugaw or kanang mga murag mga galamay-galamay dira mo na ang inyoha ang ato ang mucus threads. Alright? So we have here your starch granules, di ba? Note ang ato ang dimpled centers, pollen grain, di ba? Katuning ato ang mga mistaken as your RBCs. So fecal material, of course. Then your fiber, usually nadyo na si fiber present always. And then kani diaper fiber, vegetable fiber. Alright? So, diri na ta sa microscopic quantitation. Alright? So, ato ang cast, LPO ni siya, we use HPO only for confirmation. Okay? To scan for cast, the entire cover slip should be examined. Also, cast and heavy sediments tend to be pushed towards the edges of the cover slip. Okay? So, muna akong gingon na we have to jud scan for the cover slip gid kay dira jud na sila magtambay, okay? So ato ang HPO kay muni. All right? So alright, so muni ato ang reporting karon. So naakoy mnemonic ani, this was not my original mnemonic jud guys. Sa kuan lang ni sa I learned this during review days and I'm sharing it with you kay it really helps you guys as in to know. I hope makita rin ninyo. Wait. Ala. Ay, daraday. Okay. So, first off, we have your RF MOMA. Ay, RF MOMA. Ay, joke. Sorry, guys. RF MOMA or your rare few moderate many. Alright. So, wait. If HPF, we use the mnemonic as your kuan medyo binastos ni siya guys kay lalabi sila na kuan. If binastos, mas dali makakuan ang students. So, muni. C, if HPF, you have your titibayan. O, di ba? Titibayan. Or pwede pangkuan, pangkuan sa inyong self na murag, yes, titibayan ko to guys. Ano, ambot ka mo, bitaw. Basta, titibayan mo na siya. So, we have your trichomonas. And then, your transitional epithelial cells, your TECs. Ay, di na siya makita. TECs. And then, we have your bacteria, your yeast, and then your normal crystals. Alright, and then if LPF, we use the term, diba? Another ko na po, mucous sex. O, diba? Mucous sex. Mucous sex stands for, simple lang, mucous threads and your squamous epithelial cells. Okay? So again, RF MOMA, rare few, moderate many. HPF, titibayan. Trichomonas, transitional epithelial cells, you have your bacteria, your yeast, and your normal crystals. Whereas your LPF, we have your mucous sex. Okay? Duara na kabuk, mucous sex, mucous threads, and squamous epithelial cells. Dayon, if average, di ba, average number we have here. So, HPF, we use the RAR. Charot. RAR na, what do you call this? Mnemonic. So, RAR stands for RBC. We have your oval, fat bodies. Sorry guys, dugay kay kumakatype. Oval fat bodies. We have your WBC and of course your RTE cells. Okay? And then if per LPF, we use the cast crabs. Cast crabs. So cast crabs, duwa ra Japon ni, take note jud guys, basta LPF duwa ra siya kabog. Cast and abnormal crystals. Ana lang, okay? So again, average number, HPF, your ROR, your RBC, oval fat bodies, WBC, and your RTE cells. If LPF na average number, we have your cast crabs. So gibalira ni guys sa abnormal crystals and then your cast. Alright? So, ano siya, I hope this helps guys. Please lang kog note ani. Okay? Alright? So, balik ta. So, we have here your reporting, di ba? Kay naman tayo RF MOMA. RF MOMA. So, ma'am, kanang sama siya ma-use aning RF MOMA. So, kani ato ang ginagamit. Alright? So, we have here your quantification. So, one thing to take note, si epithelial cell, LPF, si crystals na to, di ba? Ato ang normal crystals, di ba? Kay HPF. Bacteria is HPF. Mucus thread is LPF. So, LPF, HPF, HPF, LPF. Okay? So, non-seen is 0. Rare, depende siya sa epithelial cells. We have 0.0 to 5, 0 to 2, 0 to 10, 0 to 1. We have few here. So 5 to 20, 2 to 5, 10 to 50, 1 to 3. And then moderate, we have your 20 to 100, 5 to 20, 50 to 200, 3 to 10. And then your many or abundant, greater than 100, greater than 20, greater than 200, greater than 10. Okay, so you should memorize this guys kay kuan. It is very important manggod kay para in kaso natay activities pohon dili mo dili mo maglisod ba at least kabalo na mo. Okay? And then if yeast gani guys, yeast parasites and spermatozoa, we usually report this as usually seen or non-seen Regine. All right. So sample tally sheet here. So hala wala nakita ang ubos. Hala. Ay. Wait sa guys. Ay, hala. Dili pa ta end. Alright. So, basta na note diri guys, each type of cast and crystal is quantitated and reported separately. So, careful lang mo, okay? So, mani siya akong gingon, LPO. So, cast. So, inyong lang tawon ang pinakagamay, okay, sa average niyo guys, average. Pag lantaw ninyo, ang pinakagamay sa 10 fields, okay? So, this is 0. So, 0 ang ibutang sa pinakagamay. Dayon, pinakataas ang imong ibutang. So, ang naaraman diri kay 2. Alright? So, for example, naa kay kuan diri, ang pinakagamay, walay 0 kang makitaan, ang imong pinakagamay is 3, pinakadako is 10. So, imong ibutang kay kuan 3 to 10. Okay? Alright? So, kani, based na ni siya sa ato ang gingon ganiya, few. Alright? Rare. Or rare per LPF, depende na siya per institutional what do you call this? Institutional what do you call this? Protocol, okay? Pero if yeast, mo na siya seen, and then, di ba, nagingon man taga niya na pwede po siya RF MOMA. So, depende lang. Alright? Okay. So, mo na siya tong sample tally sheet. Alright? Okay, so that ends our third part of your routine urinalysis, which is your microscopic examination, guys. Finally, nakalahos na jud ta ani, guys. And then, I hope you learned something, guys. I've done sa ato ang lecture. I hope na this somewhat helps. And if you have any questions, guys, please do message me through Facebook if you have any violent reactions or kuan ka nang nalibgan mo. Please do send me a message, okay? All right. So thank you so much, guys. Have a great day. Goodbye.